There is a list. It was created by the American Geriatrics Society. It is updated every 3 years by a panel of the country's leading physicians who specialize in caring for older adults. It is called the Beers Criteria, and it identifies the medications that are most likely to cause serious harm, falls, kidney failure, dementia, heart attacks, and death in adults over 65. Here is the part that should stop you cold. Many of the medications on that list are sitting in your medicine cabinet right now. Some of them were prescribed by your own doctor. Some of them you have been taking for years, trusting that because a physician gave them to you, they were safe. And some of them are over-the-counter pills you pick up at the pharmacy without a second thought. I am not here to frighten you. I'm here to give you the information you deserve to have so that you can have an informed, honest conversation with your doctor about what is in your body and what it may be doing to you. My name is Dr. Shan Clark, and today we are going to talk about the 6 most commonly used medications that are officially listed as potentially dangerous for seniors, what they are, what they actually do inside an aging body, and what safer alternatives exist. Write these down. Share this video, because this information could genuinely save someone's life. Why medications work differently after 60 burnout. Before we get into the 6 medications, I need to explain something fundamental, because without this context, nothing else on this list will fully make sense. Your body does not process medications the same way at 65 or 70 that it did at 40. This is not opinion. This is documented, well-established pharmacology. 2 things happen as we age that change everything about how medications behave in our bodies. First, kidney function declines. We have talked about this extensively in this series. By the time you are 65, your kidneys are filtering blood at roughly 60 to 70% of the capacity they had at 35. By 75, that number is often lower. Your kidneys are responsible for clearing most medications out of your bloodstream. When kidney function is reduced, medications stay in your body longer. They accumulate. What was a therapeutic dose at 40 becomes a toxic dose at 70, not because the pill changed, but because the organ that removes it is working at a fraction of its former capacity. Second, liver function declines. Your liver metabolizes medications. It breaks them down into forms the body can use or excrete. As liver function decreases with age, this breakdown process slows. Again, drugs linger longer. Effects are stronger. Side effects are more pronounced. Dangerous interactions become more likely. Add to this the fact that the average senior over 65 in the United States takes between 4 and 7 prescription medications simultaneously. And you begin to understand why the American Geriatrics Society created the Beers criteria in the Beers. First place, what was prescribed for one condition in one dose for one age group may be entirely inappropriate for a 70-year-old managing multiple conditions with multiple other medications already in their system. This is not your doctor's fault. Most physicians receive very little training in geriatric pharmacology. A drug prescribed by a cardiologist may interact dangerously with a drug prescribed by a rheumatologist, and neither specialist has the full picture. This is exactly why you need to know this information. Let's go through the 6 medications. Medication number 1, NSAIDs. We have touched on this one before in this series, but it belongs at the top of this list because it is the most commonly self-administered dangerous medication in the senior population. Non-steroidal anti-inflammatory drugs, NSAIDs. They are in every pharmacy, every gas station, every grocery store. They do not require a prescription, and the packaging implies they are safe for general use. But the Beers criteria list NSAIDs as potentially inappropriate for seniors, and the reasoning is specific and serious. Here is what NSAIDs do inside an aging body. To your kidneys, NSAIDs block a class of compounds called prostaglandins. These prostaglandins are part of the system that maintains adequate blood flow to the kidneys. Block them, and kidney blood flow decreases. In a young adult with healthy kidneys, this temporary reduction causes no lasting damage. In a senior with already reduced kidney function, it can tip the balance into acute kidney injury. And with chronic daily use, which many seniors engage in for arthritis or back pain, it accelerates the progression of chronic kidney disease significantly. To your stomach, NSAIDs are notorious for causing gastrointestinal ulcers and bleeding. They damage the protective lining of the stomach and intestinal tract. Gastrointestinal bleeding from NSAID use sends hundreds of thousands of Americans to the hospital every year. In seniors, this bleeding can be severe and life-threatening before any symptoms appear. To your heart, this is the one that surprises most people. NSAIDs increase the risk of heart attack and stroke. They promote fluid retention, raise blood pressure, and interfere with the blood-thinning effects of medications like aspirin. In a senior who already has cardiovascular risk factors, which is most seniors over 65, this additional risk is significant. The FDA has placed its strongest black box warning on NSAIDs for cardiovascular risk and gastrointestinal bleeding. What should you do instead? For mild to moderate pain, acetaminophen, taken at the correct dose and not combined with alcohol, is significantly gentler on kidneys, stomach, and cardiovascular function. For joint pain and arthritis, topical diclofenac gel applied directly to the affected joint delivers anti-inflammatory effect locally with minimal systemic absorption. Physical therapy, gentle movement, and warm water exercise have strong evidence for reducing chronic joint pain over time. If you are currently taking NSAIDs daily, please bring this specific conversation to your physician. Ask for a review of alternatives and ask them to check your kidney function if they haven't recently. Medication number 2, Benzodiazepines. This one is prescribed by physicians for anxiety, panic attacks, and insomnia, and it is one of the most widely prescribed drug classes in the country for adults over 65. It is also one of the most dangerous ones on the Beers criteria list. Benzodiazepines brand names include Xanax, Valium, Ativan, and Klonopin work by depressing the central nervous system. They calm anxiety, they promote sleep. In the short term, for acute situations, they can be appropriate. But here is what happens when seniors use them regularly. As we age, the brain becomes significantly more sensitive to central nervous system depressants. The same dose of Xanax that produced mild relaxation in a 45-year-old produces heavy sedation, confusion, and motor impairment in a 70-year-old. And because the aging liver and kidneys clear benzodiazepines more slowly, these drugs accumulate in the body. Half-life extends dramatically. What was a nighttime sleep aid keeps working into the next day and the day after that. Seniors on regular benzodiazepines are often functioning in a state of chronic, low-grade sedation without realizing it. The consequences are severe and well documented. Falls. Benzodiazepines are one of the leading pharmaceutical contributors to falls in seniors. And in an older adult, a fall is not a minor inconvenience. Hip fractures in seniors over 75 carry mortality rates approaching 20 to 30% within 12 months. Memory impairment and cognitive decline. Benzodiazepines impair the formation of new memories and accelerate cognitive decline with prolonged use. Multiple studies have linked long-term benzodiazepine use to significantly higher rates of dementia diagnosis. Dependence. These medications are physically addictive. Stopping them abruptly after prolonged use can cause dangerous withdrawal, including seizures. Many seniors are on benzodiazepines they can no longer safely discontinue without careful medical supervision. Dangerous interactions. Benzodiazepines, combined with opioid pain medications, a combination alarmingly common in older adults managing chronic pain, carry an FDA black box warning for increased risk of respiratory depression and death. The American Geriatrics Society recommends against benzodiazepine use for anxiety and insomnia in older adults except in very specific, limited circumstances. Safer alternatives for anxiety include cognitive behavioral therapy, which has a strong evidence base for long-term anxiety reduction. Buspirone is a non-addictive anti-anxiety medication that does not carry the same risks as benzodiazepines. SSRIs used at appropriate low doses are often more appropriate for chronic anxiety in seniors. For insomnia, sleep hygiene, cognitive behavioral therapy for insomnia, and addressing the underlying causes of poor sleep are far safer long-term approaches. We discussed the importance of sleep extensively in our earlier videos. If you are currently on a benzodiazepine and want to discuss stopping, please do not stop abruptly. Work with your physician on a supervised, gradual tapering plan. Medication number 3, sleep aids with diphenhydramine. This one is sold in every pharmacy without a prescription. It is marketed with images of peaceful, sleeping seniors. It is taken by millions of older adults every single night as a harmless way to get some rest. And it is one of the most concerning medications on the Beers criteria list for cognitive health in seniors. Diphenhydramine is the active ingredient in Benadryl, ZzzQuil, Tylenol PM, Advil PM, Unisom, and many other sleep and allergy products. It works by blocking a neurotransmitter called acetylcholine. Acetylcholine is essential for memory formation, attention, and cognitive processing. It is the same neurotransmitter that is deficient in Alzheimer's disease. When you block acetylcholine with diphenhydramine, you are chemically mimicking, at least in part, what Alzheimer's disease does to the brain. In young adults, this effect is temporary. The drug clears quickly. Cognition returns to baseline. But in seniors, diphenhydramine clears much more slowly due to reduced kidney and liver function. And the aging brain is already producing less acetylcholine baseline. Blocking more of it produces acute confusion, disorientation, memory impairment, and in some seniors, a state that closely resembles delirium. The Beers criteria specifically lists diphenhydramine as potentially inappropriate for seniors due to its strong anticholinergic effects. And the long-term data is particularly alarming. A landmark study published in JAMA Internal Medicine followed nearly 3,000 older adults for 7 years and found that those who used anticholinergic medications like diphenhydramine at high cumulative doses had a 54% higher risk of dementia than those who did not. 54% higher risk of dementia from the same pill sold in every pharmacy as a safe sleep aid. The FDA updated its labeling for diphenhydramine sleep aids in 2023 to include stronger warnings about cognitive risks in older adults. What should you use instead? For occasional sleeplessness, melatonin at low doses, typically between 0.5 milligram and 1 milligram, is considered far safer for seniors and is not associated with cognitive risk. For chronic insomnia, cognitive behavioral therapy for insomnia is the evidence-based first-line treatment. It addresses the root behavioral and psychological causes of poor sleep without any pharmacological risk. For allergy symptoms, second-generation antihistamines like loratadine, Claritin, or cetirizine, Zyrtec, do not cross the blood-brain barrier to the same extent and are considered significantly safer for seniors than diphenhydramine. If Benadryl or a PM sleep product is currently in your medicine cabinet, this is the conversation to have with your doctor at your next visit. The safer alternatives are real, accessible, and effective. Medication number 4, Proton Pump Inhibitors. This one is going to surprise many of you because proton pump inhibitors, PPIs, are extraordinarily widely used. They are prescribed for heartburn, acid reflux, and stomach ulcers. Many seniors have been taking them for years. Some take them indefinitely. And while they have genuine, appropriate uses, their long-term use in seniors carries risks that are seriously underappreciated. Proton pump inhibitors work by dramatically reducing stomach acid production. They are highly effective at this. But stomach acid is not simply an irritant, it serves critical functions. Stomach acid is essential for absorbing several nutrients that are profoundly important for senior health. Magnesium. Long-term PPI use is associated with significant magnesium depletion. And magnesium, as we discussed in our earlier videos, is essential for blood pressure regulation, sleep quality, nerve function, and muscle health. Hypomagnesemia from PPI use has been linked to cardiac arrhythmias, muscle cramps, and neurological symptoms. Calcium. PPIs reduce calcium absorption. Over years of use, this contributes meaningfully to bone density loss and increased fracture risk, particularly hip fractures, which are a leading cause of disability and death in older adults. Vitamin B12. Stomach acid is required to release vitamin B12 from food. Long-term PPI use can cause B12 deficiency, and B12 deficiency in seniors produces serious neurological symptoms, including memory loss, difficulty walking, and numbness in the extremities that closely resembles neurological disease. Iron. Reduced stomach acid impairs iron absorption, contributing to anemia in seniors already prone to it. Beyond nutrient depletion, long-term PPI use is associated with increased risk of Clostridium difficile infection, a serious gastrointestinal infection that is disproportionately dangerous in older adults. It is also associated with increased risk of pneumonia and kidney disease with prolonged use. The American Geriatrics Society and multiple gastroenterology guidelines recommend that PPIs be used at the lowest effective dose for the shortest necessary duration, and that long-term indefinite use be regularly reviewed and justified. Many seniors who were started on a PPI years ago for a temporary condition are still on it simply because no one reviewed whether they still needed it. If you have been on a proton pump inhibitor for more than 8 weeks, ask your doctor whether continued use is still indicated for your specific situation. Ask about the lowest effective dose, and ask about supplementing magnesium, calcium, and B12 if you're going to continue. Medication number 5, sleeping pills. Z-drugs. Z-drugs, zolpidem, esopiclone, zaloplan, sold under brand names like Ambien, Lunesta, and Sonata, were marketed as a safer alternative to benzodiazepines for insomnia. They are not safer for seniors. The FDA now recognizes this explicitly. In 2023, the FDA issued an updated black box warning, its strongest possible warning for zolpidem and related Z-drugs, specifically noting the risk of complex sleep behaviors, including sleepwalking, sleep driving, cooking and eating while asleep, and making phone calls, all without any memory of these behaviors upon waking. These are not rare events. These are documented, recurring phenomena that have caused serious injuries and deaths. And in older adults whose balance and coordination are already more vulnerable, the risk of injury from these sleep behaviors is particularly acute. Beyond the complex sleep behavior risk, Z-drugs carry many of the same risks as benzodiazepines in seniors. They cause daytime drowsiness and cognitive impairment that persist into the following day. They significantly increase fall risk. They impair driving ability, which is why the FDA specifically requires that women and elderly patients use a lower dose, because these drugs clear more slowly in their systems. The Beers criteria lists zolpidem and other Z-drugs as potentially inappropriate for older adults. And critically, like benzodiazepines, these drugs are habit-forming. Many seniors are taking them nightly, have been for years, and find that they cannot sleep without them. This dependence itself becomes a medical problem that requires careful management. What should be done instead? Cognitive behavioral therapy for insomnia, CBTI, has been shown in multiple clinical trials to produce better long-term sleep outcomes than sleeping pills, without any of the risks. It addresses the thought patterns, behaviors, and sleep hygiene factors that perpetuate insomnia at a fundamental level. Melatonin at low doses, taken 30 to 60 minutes before bedtime, can help regulate the sleep-wake cycle in seniors whose melatonin production has declined with age. If you are currently on Ambien or another Z drug, please do not stop abruptly. Bring this conversation to your doctor and discuss a supervised tapering plan alongside non-pharmacological sleep support. Medication number 6, muscle relaxants. The sixth medication on this list is one that surprises almost everyone who hears it, because muscle relaxants seem straightforwardly appropriate for an older adult dealing with back pain, muscle spasms, or arthritis. But the Beers criteria specifically flags muscle relaxants, including cyclobenzaprine, Flexeril, carisoprodol, Soma, and methocarbamol, as potentially inappropriate for seniors. Here is why. Muscle relaxants work by depressing the central nervous system, and as we have established, an aging brain and aging nervous system are far more sensitive to central nervous system depressants than are younger adults. The result in seniors is not simply relaxed muscles. It is sedation, confusion, disorientation, impaired coordination, and significantly increased fall risk. Falls, as we have discussed, are one of the leading causes of injury-related death in adults over 65, and muscle relaxants are among the medications most strongly associated with fall risk in this population. There is also an anticholinergic component to some muscle relaxants, meaning they carry the same cognitive risk as diphenhydramine. The combination of sedation and anticholinergic effects in a senior taking a muscle relaxant for back pain can produce acute confusion, delirium, and significant memory impairment. And critically, the evidence for muscle relaxants actually relieving musculoskeletal pain effectively in older adults is weak. The side effects are significant. The benefit is questionable. The American Geriatrics Society's position is that the sedative and anticholinergic side effects of muscle relaxants are almost always more significant than any pain relief they provide in this age group. Safer alternatives for musculoskeletal pain in seniors include targeted physical therapy, which addresses the underlying mechanical causes of pain. Topical pain relief agents, menthol creams. Topical diclofenac gel, warm heat applied directly to the affected area. Gentle, appropriate movement, which research consistently shows reduces chronic musculoskeletal pain more effectively over time than sedative medications. If you or someone you care for is taking a muscle relaxant regularly, this is absolutely worth raising with the prescribing physician. I want to give you something practical to take out of this video, because information without action is just anxiety. And I don't want to leave you anxious. I want to leave you empowered. Here is a step-by-step plan for taking control of your medication situation. Step 1, make a complete medication list. Write down every single substance you put in your body, every prescription medication, every over-the-counter medication, every supplement, vitamin, and herbal product. Include the dose and how frequently you take each one. This list may be longer than you expect, and seeing it all in one place is a genuinely clarifying experience. Step 2, request a medication review appointment. Contact your primary care physician and ask specifically for a medication review appointment. Not a regular checkup, a dedicated appointment whose specific purpose is to review your full medication list, identify any duplications, interactions, or inappropriate medications, and discuss whether everything on the list is still necessary and still the best option for your current situation. If your doctor's practice has a clinical pharmacist on staff, request a consultation with them. Clinical pharmacists who specialize in geriatric medications are extraordinarily valuable and underutilized. Step 3, ask the right questions. For every medication on your list, ask your physician the following. Is this still necessary for my current condition? Is this the safest option for my age? Could any non-pharmacological approach replace or reduce my need for this? Are there interactions between this and my other medications that I should know about? And how does this affect my kidneys or liver over time? These are not difficult questions. They are reasonable, important questions that every senior has the right to ask and have answered. Step 4, never stop a medication abruptly without supervision. I want to be very clear about this. The purpose of this video is not to encourage you to empty your medicine cabinet tomorrow morning. Some of the medications on this list, particularly benzodiazepines, Z-drugs, and certain others, can cause dangerous withdrawal effects if stopped suddenly. The goal is informed conversation with your physician, not self-discontinuation. Step 5, become your own best advocate. The reality of modern medical practice is that your physician may have 15 minutes with you. The Beers criteria, your full medication list, and all of its implications are difficult to cover comprehensively in that time. The more informed you come into that appointment, the more productive it will be. Print out this medication list. Bring it to your appointment. Tell your doctor you want to review each item specifically with the lens of what is most appropriate for your age. You deserve that conversation. Your health depends on it. Let me bring this home. Nearly 90% of adults over 65 take at least one prescription medication regularly. More than 40% take 5 or more. And the American Geriatrics Society has documented clearly and specifically that a significant percentage of those medications carry risks for seniors that outweigh their benefits. Risks that most seniors have never been told about. This is not about distrusting your doctor. Your physician is not your adversary. They are working in a system that does not always allow the depth of conversation that your situation deserves. This is about you having the information to be a more informed, more active participant in your own health care, to ask better questions, to understand what is going into your body and what it may be doing there. The 6 medications we discussed today: NSAIDs, benzodiazepines, diphenhydramine sleep aids, proton pump inhibitors, Z-drug sleeping pills, and muscle relaxants are among the most commonly used and most frequently flagged as potentially inappropriate for seniors by the world's leading geriatric medicine experts. Check your medicine cabinet, make your list, have the conversation. I'm Dr. Shan Clark. If this video helped you understand your medications better, please share it with someone you love who is over 60 and managing multiple prescriptions. Subscribe for a new video every week covering the senior health topics that matter most and that don't always get the attention they deserve in a standard doctor's appointment. And leave a comment below telling me which of these 6 medications were you surprised to see on this list. Take care of yourself. I'll see you next week.